So this second screencast is going to take us through one or two of the things that are constantly debated in health promotion. So it's not a kind of this is health promotion and we know exactly what we're doing and everything is all completely agreed. There's quite a lot of discussion about it because it's an evolving discipline. So as life changes, health promotion changes. So we've got a few things to just talk through briefly. So firstly is this idea of health promotion activities either fitting into one of two groups really. And the first one is a medical or educational activity, which is seen as individualist or individualist. So this is where the individual themselves, the person, is blamed. And so there's this negative idea of health. So, for example, someone with lung cancer who's been a long-term smoker might be seen as being blamed. So we're trying to educate people to stop smoking because otherwise they are at risk of lung cancer and that would be their fault. It's that kind of way of looking at things. The second one is the opposite. It's saying that the individual doesn't have any role at all, and it's all to do with society and politics and culture. So everything is influenced by those wider determinants, in effect. So this is seen as a more positive conception of health in some ways. Within each of these, you've got to consider these ethical issues. Are we blaming someone for something that they actually have very little control over? How are we looking at that? And how are we treating an individual with our NHS values of respect and dignity and all of those kinds of things? So some might see it operating at different levels that we've talked about, but these are often seen as polar opposites. So the ecological approach is really combining those two things. So it's combining that kind of structure approach and the individual approach. So we might look at personal factors, but we will consider the environmental factors as well. And this example of somebody who you might see in a kind of dietetic scenario, somebody with borderline hypertension. So we know that blood pressure can be reduced with dietary change, lowering body weight, increasing physical activity, changing salt consumption. But the service user needs to know what to do. So there's that educational aspect. But in order for us to expect any of that education to be transferred into action, we've got to think about, well, what can they afford? And what do they have access to? What's available to them? So we've got to enable people to follow advice that's appropriate for them. So you could have a row of people with borderline hypertension, but you could also have all of those different widened determination. Start again. There. So in this second screencast, we're going to look at some of the aspects of health promotion that lead to some quite debate in the scientific and research world. And this is because health promotion is still very much in development, and we're learning new things, new ways of doing things all the time. So there is some debate on key issues affecting it. And this is one example where all of the activities either are meant to slot into one or the other of these two groups. So the first one is this medicalized educational activity. So this is where the individual is seen as in complete control of everything and they should just change based on what we teach them. So it's a negative concept of health and suggesting that it's all down to the individual. The second one is the opposite. It's saying, well, actually, it's a social thing. So the individual has no control. It's all down to their social life, their wider determinants of health, the politics, their culture. So you blame the system. And therefore you can get a situation there where people feel completely disempowered to do anything because, well, the system's all at fault. It's not my fault. It's all down to the system. So you've got one where you blame the individual, and so it's all down to the individual, and one where you see that it's society and the structures. And we've got to think about this from an ethical perspective as well. Is it ethical to just blame an individual? But also, is it ethical to take away that control from an individual by saying, it's purely, down to your situation. There's nothing you can do. So those two things can be looked at in a different way. And I personally much prefer this approach called the ecological approach, where you put the two together. And I think this sits very well with our ideas of how dietetics works. So we look at the personal factors, the person, and we look at those wider determinants of health or the environment. So individual and structure. So if we've got a person with borderline hypertension, high blood pressure, for example, we know there's lots of evidence to show that blood pressure can be reduced by dietary change, decreasing salt intake, for example, but also by lowering body weight if someone is overweight and increasing physical activity levels. So we're asking for some change there in the individual behavior. So cut your salt intake down, cut down your calorie intake, start moving more. But we've got to make sure that people have the correct information. So we've got that health education aspect of it to make sure people actually know what foods have salt in them. But the advice would also need to take into account their income, how affordable the foods that would be recommended would be, and the availability of those foods and their culture and all of those other things. So if we do those things together, we enable people to follow the advice. And that advice, therefore, will be tailored to that person in front of us. And that's a really important way and part of what person-centered care is in dietetics. So another way of looking at the different approaches to health promotion are on this table here. So we've got the medical approach. So that's very much focusing on disease, those at risk from disease. And that's why we might look at must screening on hospital wards, for example, or in community care to find out whether someone's at risk of malnutrition. We might do screening for bowel cancer or breast cancer because we're looking for a disease and we're trying to therefore deal with that disease. Then we have the behavior change approach. So we are trying to get people to take responsibility for their own health. So, that individual. And we're trying to enable them to look after themselves, manage their diabetes, for example. Some of that might use mass media to try and change the environment to make people think behavior change is possible as well. We have our educational stuff, which we've talked quite a bit about already. But the empowerment module where you're working with communities. So you're looking at a particular geographical area or a particular community, saying, well, what are their needs? How can we support them and work towards meeting their needs as a community? And that's where your advocacy and networking, partnership working will fit in. And then there's this idea of changing society. So this is about changing the inequalities, looking at that population and trying to make things easier for individuals within that population to have a healthier lifestyle. So that's like the whole levelling up agenda, which doesn't seem to be terribly productive at the moment, but the idea that North and South in the UK shouldn't be different, but they are. And sugar tax, which goes right across the population, trying to decrease sugar intake in the population. So again, different ways of approaching things. So you might want to stop the screencast for a moment and just think through which of these activities are promoting health. How do they do that? And what kind of approach might they be taking? Another way to look at differences in health promotion practice is to look at who it's targeting and how. So it can work through a number of different levels. So health promotion does include the individual, and using smoking is a very different example. But so someone can have one-to-one counselling on stopping smoking, or they might be prescribed some nicotine replacement therapy of some kind. So that's about what we do with the individual. It might be that you're trying to get some family support here. So if you've got one out of a couple that is a smoker and the other that isn't, but you might want to bring them together to learn how to support each other. Or if we're looking at a community where the incidence of smoking is still quite high, so is that an area where we need to actually put a stop smoking clinic or smoking cessation service into that community to make it more accessible to people? If we're looking at a bigger geographical area, local council, Nottinghamshire, for example, or a district council, you might want to then think, right, okay, let's make sure that the smoking bans are being adhered to. So let's up the police presence or the CCTV or whatever to try and make sure that that smoking ban is actually adhered to properly. And then you might have a regional thing, which we have every year, I think is in October. We have Stoptober. So that TV campaign promoting non-smoking, and that can be done regionally, or it could be done nationally. But nationally also, we might be lobbying government, stop any incidents of sponsorship of events by tobacco companies, and there's very little of that happening now. And international, we had the WHO coming up with a tobacco framework to control smoking, because it's a global issue. It's not just a local issue, smoking. It's a global problem. So you can see that over the years, there's lots of different ways that we can look at that level of health promotion. Another aspect of it is to what extent we empower, we try to persuade people, or we coerce them. And it's worth thinking when you're doing something, actually, what am I trying to do here? Am I pushing people? Am I giving them gentle persuasion, or am I empowering them to take control? So have a few thoughts on what that might mean, and what the pros and cons of those approaches might be. Are you taking control away from someone or giving it to them? What's ethical to do and what isn't? The time for prevention is relating to the prevention at different stages of illness development. So primary is trying to stop a disease occurring in the first place, trying to decrease the incidence of overweight or lung cancer, for example. So we might be promoting physical activity and healthy eating to decrease the number of people living with overweight and obesity. But there are people who are already living with overweight and obesity. So the secondary prevention is trying to decrease that getting worse, or to deal with it and support people to get back down to a healthy weight. So that example there, trying to get people down to a healthy weight, or reverse type 2 diabetes, which if in the early stages is feasible to do. The tertiary prevention is recognizing that actually some conditions can get worse and can cause more disability or more complications, like diabetes, for example. So therefore, you might be wanting to support people living with type 1 diabetes to manage their condition better, and therefore decrease the risk of them going on to develop long-term complications. Or if they've got long-term complications, want to manage those so they don't deteriorate. So prevention can happen at all of those stages. So going back to your tasks that you were thinking about earlier, or the activities, have a look and think, well, which approach have we got here? And what level is it at? So thinking of the things you looked at earlier, just add some thoughts at which type of approach and what level it might be being delivered at.